Yes, it's a pleasure to be here talking to you. Very strange to be talking to my computer screen, but hopefully it'll all work out well. So I've been asked to talk about pulsatile tinnitus, its assessment, diagnosis, and treatment. So why pulsatile tinnitus? I think I've looked at pulsatile tinnitus and studied it for over 10 years, and I find it a fascinating symptom. It is a poorly understood symptom. It seems to affect a number of different specialities, including neurologists, neurosurgeons, and ENT surgeon. And I think it suffers for that. I think it has a problem in that it doesn't find a true home for those a group to really study it in detail. It is often only a mild nuisance for patients, and they're not really troubled by it too much. But for some, it can really dominate their life. If you try to look at the prevalence, it's thought to be about 4% of all tinnitus sufferers, and as 1 in 10 of the population have tinnitus, one could surmise that there is a prevalence in the UK of about 250,000. And it is a harbinger symptom. So it is a symptom that could present early and potentially signal that there's a more serious outcome, a serious illness to come. Yet the majority of patients who are investigated extensively find little wrong with them, and these investigations really can be very invasive. So what is pulsatile tinnitus? Well, it's the perception of pulsatile noise in time with a heartbeat, and there are thought to be 3 ways in which this can occur. So you can have an abnormal hearing organ that is hearing a normal sound generated within the body. You can have a normal hearing organ that is hearing an abnormal sound that's being generated somewhere that can be picked up by the aortic capsule. Or you can have an abnormal hearing organ generating an abnormal sound. And I'm going to give 3 examples of this before going into more detail. So this is the hearing organ. I won't go into that in any more detail other than that's what the organ is. And if you want to look at a classic example of abnormal hearing organ hearing a normal sound, one would consider superior semicircumcanal dehiscence. And I'll go into this pathology later, but essentially it is the opening up of a 3rd window into the aortic capsule, and this 3rd window is connected to soft tissue and the body generally, and allows sounds intracranial sounds being delivered through the balance organ into the cochlea, so it is perceived as pulsation. This is a subjective tinnitus. We can't hear it if we listen to the temporal bone with a stethoscope. It is purely a sound heard by the patient. An example of a normal hearing organ hearing an abnormal sound, the classic, of course, is a dural fistula. This is a high flow fistula. This is a fistula that passes blood from the artery to the veins in high volume. And this creates a bruit, and this bruit is heard by a normal cochlea, and it's regarded as being an objective tinnitus. So not only can the patient hear it, but the partner can often hear it when the room is quiet. They will often come with a recording of it on their iPhone, and if you listen with a stethoscope, you'll find that you get this whooshing tinnitus that's quite easy to hear. And if indeed you do hear that, then one needs to consider a dural fistula. An example of an abnormal hearing organ generating an abnormal sound, well, I suppose the classic one is the somatic pulsatile tinnitus. And this is an important because it's not that uncommon. And the difference is that this is a high frequency hissing or ringing tinnitus. It's not the typical whooshing or banging or thumping tinnitus. And it's often accompanied by multitonal tinnitus. So patients will also describe high frequency, changing, constant tinnitus. And This is often associated with a sensorineural hearing loss and hyperacusis, often triggered by a previous exposure to a loud and unexpected sound. And interestingly, these patients can modulate this tinnitus by pressing on their head or their face or clenching their teeth, and that can often reduce or increase the intensity of the tinnitus. And it's important to identify these patients because it can save a lot of investigation. So I'm going to start off with abnormal hearing apparatus hearing a normal sound, and one can split this into middle ear pathology and inner ear pathology. And generally, ENT surgeons are pretty good at diagnosing these. This is our area, this is our patch, we should be able to diagnose these. So before going through into the pathology, I'm going to talk about the anatomy because it's rather important. So the ossicles are suspended within an air-filled cavity. They're held between the tympanic membrane and the inner ear by three main ligaments, the anterior and superior malleol ligament and the anterior incus ligament. There's the annular ligament that surrounds the stapes footplate and, of course, the tympanic membrane. And all those hold the hearing mechanism away from the body. So although connected to the body by these structures, they are avascular and they allow sound vibration to pass in the ear. But if that ossicular chain or eardrum becomes or is in contact with the body, and that body has that substance or connection has a vascular supply, then more often than not, they will hear a pulsatile tinnitus. And it's also associated usually with a conductive hearing loss, which might be their primary symptom. So middle ear pathology that can cause pulsatile tinnitus, impacted wax sitting in the recess can allow pulsations to pass through the wax and onto the eardrum, as can middle ear effusion. But these two, their pulsatile tinnitus really isn't a problem. They're not really too bothered by it. They're more bothered by the effects of the on the hearing mechanism. So their hearing is down, they might have a bit of pain. So it really isn't an issue and often isn't there anyway. One important area though is tegment dehiscence. And if that tegment dehiscence is significant, it can lead to meningocele and meningoencephalocele developing. And that meningoencephalocele can sit on the ossicular chain. So here we've got the brain, there's a meningocele coming down, actually this is the meningoencephalocele coming down and sitting on the hearing mechanism. And that is allowing pulsations, the brain pulsations, to pass into the inner ear. And if the tegment dehiscence is really big, then one can see pulsation of the eardrum. Otosclerosis is a common cause of pulsatile tinnitus, but again is very much secondary to the primary symptom of hearing loss. And then there's the classic one that we all sort of want to exclude when somebody comes in complaining of pulsatile tinnitus, and that's the glomus or paraganglionoma. And that sits on the ossicular chain, usually wrapped around the stapes and incus, and that passes pulsations because it's a highly vascular tumour. It allows those pulsations to be passed through into the inner ear. There are occasionally, and this is very rare, aberrant vessels. And here's a picture of abnormally placed carotid that's sitting over the otic capsule. So those pulsations are being passed through into the cochlea via the dehiscent carotid, and they describe a very different sound. This is very much more a banging sound that they're aware of rather than a whooshing. So we then come to the inner ear, and that's a different group of symptoms that these patients present with. And just the anatomy part, the most important is, of course, that we've got two openings into the otic capsule, the round window and the oval window, and they open into this air-filled middle ear cleft. If anything creates a third window, and that third window has soft tissue adjacent to it, but particularly vascular soft tissue, then once again you can experience pulsatile tinnitus. But these are usually also associated with inner ear symptoms. And as we've mentioned before, this can be inner ear hearing loss or autophony, Tullio phenomenon. So this is seen in superior canal dehiscence. Here we've got a classic picture of a superior canal dehiscence. It's interesting how common this is, and often how common it is on radiological review without patients having significant symptoms. So it's only a proportion of people who have dehiscence that actually get these symptoms. And again, it's dominated by the autophony, rather less the pulsatile tinnitus. And these patients will also get the Tullio phenomenon, whereby sound, instead of being transmitted through into the cochlea, is transferred across the balance organ, which makes them dizzy with loud sounds. But also it allows the sounds then to track from the cranial cavity and into the inner ear. So that's mainly an autophony symptom. But if it involves the superior petrosal sinus, then these patients can actually get quite a significant pulsatile whooshing. And here's a classic example of the superior petrosal sinus running along the upper portion of the temporal bone, and it's nibbled away and it's affected the superior semicircular canal. And you can see it here, it's taken a sort of rat bite out of it. And these patients will more often than not present with a pulsatile whooshing tinnitus as their main symptom. But you can get tumor erosion of any semicircular canal, the most common of which, as shown here, is a cholesteatoma that's caused the labyrinthine fistula. These patients don't complain of pulsatile tinnitus unless there is also erosion of the tegmen plate. So what you've got then is you've got a conduit to enable pulsatile sounds to pass through the cholesteatoma and into the inner ear. And lastly, you can have erosion of the cochlea. This is a petrosal carotid aneurysm that's eroded the carotid, the cochlea. And I've seen a couple of patients who have apparently normal carotids passing through the temporal bone, but there is a clear dehiscence between that and the basal tone of the cochlea. And these patients typically again complain of this banging, really loud banging pulsatile tinnitus that seems to be very much part of an arterial connection to the inner ear. Now, I mentioned vestibular schwannoma, and I think one should, because vestibular schwannoma tends to present with everything. I've seen many thousands of patients with vestibular schwannoma over the 20-odd years that I've been an ENT surgeon. And very rarely do they have pulsatile tinnitus, but some do. And the reason why I mention it is this is the only pathology that requires an MR scan. Everything else is diagnosed by CT. But if a patient has an inner ear hearing loss associated with pulsatile tinnitus, then one should perform MR imaging. So I've mentioned a normal hearing organ hearing an abnormal sound. A classic is the dural arterial venous fistula. And just to go into this in a little bit more depth, the thought is that these are formed by raised venous pressure, and that, I don't know how, but in some way creates this connection between artery and vein. And some of them are aggressive and therefore can bleed. The vast majority, and often will present with a bleed, the vast majority are benign and will present predominantly with pulsatile tinnitus. So they might well present to us as ENT surgeons. And as I said, it's really important that we are careful in our examination, more or less listening to the temporal bone with the stethoscope to make sure that we're not missing one. Sigmoid sinus and jugular bulb dehiscence and diverticulum can be a cause. And here we've got a dehiscence of the sigmoid sinus, and this is thought to enable sound to pass through into the temporal bone and be picked up by the cochlea. I'll come back to that in a little while. This is a jugular bulb dehiscence. We can see it here pulsating away and close to the hearing mechanism, and that's picked up as pulsatile tinnitus on occasion, not always, on occasion. Thyrotoxicosis and the hyperdynamic state, as well as carotid artery stenosis, have been well documented. But I have to say, in all the cases that I've managed, and I've seen well over 800 patients with pulsatile tinnitus, this is a relatively rare cause as far as I'm concerned. I don't tend to see very much of that in my practice. So if you're sitting there with the patient in front of you who's complaining of a primary symptom of pulsatile tinnitus, it's important that you spend time asking the right questions. You want to know whether this is low frequency or high frequency to see whether you can identify a somatic tinnitus. You want to know that there are other symptoms. You want to know whether there's associated hearing loss, vertigo, autophony, tulio. All those symptoms are important to ask specifically, because often patients do not voice them. They think that maybe they're unrelated. So you've got to ask specifically for them. But also you've got to ask about symptoms that you would think weren't really relevant at all. And certainly the patient might not feel relevant. And that is asking around the symptoms associated with raised intracranial pressure. So headache, head pressure. They describe this head pressure as if a band is around the head wants to explode. The head is foggy, they can't really concentrate, they're tired, they've got quite poor memory. In examination, you want to find out whether it's objective or subjective, as mentioned, for the reasons stated. And then you want to see whether the intensity of the pulsatile tinnitus changes to compression of the internal jugular vein. So by pressing on the internal jugular vein, on the ipsilateral side, will often stop their pulsatile tinnitus. And interestingly, some patients will come in and volunteer this. They'll say that when they're in a meeting and they want to hear somebody speaking, they might just place their hand on their internal jugular vein, which stops the pulsating, so they can have a conversation and then release it. And often when they go to bed, they might place a pillow under their neck to try and reduce the intensity of the pulsation. Audiogram, high definition CT of the temporal bone are all very important for various reasons, and I discussed MRI of the head. So I've got these rules for the initial stages of pulsatile tinnitus, and this is based on, as I say, 800 patients that I've managed. So if it's objective, then it's nearly always a dural fistula. You've got to listen both to the head and to the neck. If it's high frequency, multitonal, then consider somatic. If it's associated with autophony, we all know, then we should consider superior canal dehiscence. If the eardrum pulsates, consider tegmen dehiscence. If there is an associated inner ear hearing loss, then consider vestibular schwannoma. And if associated with a conductive hearing loss, then it's more likely than not to be a middle ear pathology. But if you add all those up, it comes to, and all the other very minor conditions, and it comes to just over 20%. So that leaves a large chunk of patients who have no diagnosis. And in that group, one needs to think of the vascular. So this is a pulsatile tinnitus that is heard by a normal hearing ear, and they're hearing an abnormal sound. And when we talk about pulsatile tinnitus, as it is in the literature, what we really mean is a venous tinnitus. And these patients have this whooshing sound that goes through them. They describe it as a whooshing. And it often stops, as I say, by compressing the ipsilateral and jugular vein. If you press the contralateral, in some patients, the intensity gets louder. And this can be associated with other symptoms. So this is a small study I did looking at 160 patients. They performed a visual analog scale of the severity of their symptoms. And these are the percentages of patients who have got an initial diagnosis of vascular tinnitus, of those scoring over 5 out of 10, so something significant. And not all patients clearly thought their pulsatile tinnitus was too severe, so that's 92%. But you can see that certain symptoms were really quite important. For example, head pressure, this explosive head, fogginess of thought, and lethargy, poor concentration, poor memory. And these symptoms, well, they might be due to patients finding it difficult to sleep with a pulsatile tinnitus, but these symptoms are very similar to those symptoms of raised pressure, which I'll come on to a second. So you've done your initial round of investigations, you've looked for ENT causes, and you've come back more likely than not with nothing really found. And so what I tend to do then is I organize a CT venogram of the head and the neck. And I want to look at the venous flow out of the head, because this gives me a very good idea of what's going on. I then get the patients back and I have a long conversation with them about what I think is likely to be happening. Often these patients have come from quite some distance to see me, and they've been to see other surgeons before me. So sitting down and going through it, explaining that maybe there's some pressure-related cause and venous outflow cause or obstruction cause for the symptoms. But it's not life-threatening, it's not going to cause any major mishap, and further investigation and treatment is really quite invasive. And so when I have that conversation, 80% generally of the patients are happy with the explanation, are willing to accept symptoms, and they're happy to be discharged. They know they can come back and see me if necessary, some do. But 20% are really very much infected by this symptom and want further investigations, which might well include lumbar puncture to measure the opening CSF pressure, as well as seeing whether the symptom of pulsatile tinnitus and other symptoms improve by reducing the pressure. Indeed, if all evidence points in that direction, then we might go ahead and perform catheter venography to look at venous flow, pressure gradients, and stretching, balloon venoplasty of certain areas that might be narrow. And I'll explain why these things are important now. So the general consensus is that idiopathic intracranial hypertension is diagnosed with a pressure greater than 25 centimeters of CSF. And you can see here on the left that the symptoms that these patients complain of are very similar to the ones that I've just shown you in the series. This is a consensus document published in 2018 in JNMP. And it's talking about this 25 centimeters of CSF. And it's important to understand why they've chosen that. So that patients will present with all pressures and symptoms, but only some of them are at risk of serious complication, for example, visual loss. And the treatments that are on offer, as shown here, are quite significant, certainly the last two. So they only really want to be treating those patients that have got very high pressures. And that offers a problem for those patients who have pulsatile tinnitus, because often their pressures are not at a level that can meet the criteria for idiopathic intracranial hypertension. So this is a group of patients, 140 patients who've had lumbar puncture under my care for primary diagnosis of pulsatile tinnitus. And you can see about a quarter of those patients do have symptoms that would class them as idiopathic intracranial hypertension, but many are not. And many fall into what would be regarded as normal pressures. So these patients might be feeling pretty aggrieved that they're not getting a diagnosis, because the vast majority of neurologists and people that look at raised pressure will class it as normal if it's below 25 centimeters of water, because neurologists have chosen that figure for the reasons I've mentioned. So the CSF dynamics are that CSF produced by the brain, it comes through into the arachnoid villi and retinoid granulations, and then it passes down a a pressure gradient into the venous system. And that pressure gradient is 3 millimeters of mercury. So if the venous pressure goes up, then the CSF has to go up, pressure has to go up, because there's got to be this difference between the two. So if you raise cerebral venous pressure, you raise intracranial pressure. And blood flows out from the brain through the sinuses, lateral, sigmoid, jugular bulb, internal jugular vein, and it flows in a laminar way. It doesn't pulsate. This is the pulse waveform, this dotted line of sinus venous flow. And for anybody unfortunate enough, as I have on a number of occasions, to make a hole in the lateral venous sinus or jugular bulb, they'll see this constant flow. It is not a pulsating flow like an artery. But as you go down lower into the neck, of course, you've got this back pressure from the heart pulse, which gives you a much more of a waveform. But within the head, it's a laminar flow. And in some patients, this flow is very much dominating one side. So these patients who've got red, they've got very little flow on one side. And indeed, this patient has only got flow out of his left internal jugular vein. So this patient could be regarded as having a dominant vein that's taking the majority of his blood out of the head. And that's important for a reason, because although that patient is normally has got no other symptoms, if there is physiological compression of that internal jugular vein, then you are reliant on the other routes of flow, the contralateral flows and the other veins, to get the blood out of the head. And so I want to describe two patients to you, and then a bit of literature before we go on to the treatment. So this was one of the first patients that I had referred to me and got my interest in pulsatile tinnitus. This was a 36-year-old lady who underwent surgery, encountered massive bleeding after making the incision just behind the ear to repair a perforated eardrum. That bleeding could not be controlled. A number of reoperations were performed, and eventually what was thought to be mastoid emissory vein was packed off with BIP, and the patient came over to see us. She presented with severe headaches and failing of vision. She had this thumping pulsatile tinnitus and quite severe papilledema. And this is her CT scan. It shows the BIP packing sitting in the lateral venous sinus, extending down through the sigmoid sinus and into the jugular bulb, so completely filling the right side. And that, shown here on the MR scan, with thrombosis of the transverse sinus and no flow or very little flow coming out of the contralateral side. So this patient has had their only outflow blocked. So she was stented, this is 10 years later, she was stented, she had to have contralateral stents, and actually she's improved a great deal. She's much better. She's got no papilledema. She still has headaches, but much better. So this is a case of a patient who has very dominant unilateral flow that when compromised leads to these symptoms, but also to this pulsatile tinnitus. And there was a phase in the literature when lots of patients or lots of papers were describing ligation of the internal jugular vein for this venous hum or vascular tinnitus. And the idea was that if you could stop it with pressure over the internal jugular vein, then why not tear off the internal jugular vein? But that does have consequences. So this patient was referred to me. She's a 35-year-old lady who had control of pulsatile tinnitus by pressure over the right neck. And the surgeon, to cut a long story short, ligated the internal jugular vein. She woke with severe headaches, similar to the previous lady. She was in hospital for some time, and she had this banging pulsatile tinnitus. So her pulsatile tinnitus got worse, and then she also had these other symptoms that now presented. And so she came down to see our team. This is the ligated internal jugular vein, and she's got a very small flow coming on which is here, on the contralateral side, and she's pretty much kept going because of this massive mastoid emissory vein that's allowing blood to escape the head into the occiput. So she had a styloidectomy, a venous vein into position, and some stents placed in, and all her symptoms went. And in fact, she was better after that than she was before she presented to the surgeon. And that's because we'd opened up her internal jugular vein to improve flow through the vein. And I think this is an important point to add, that this sort of physiological unilateral venous outflow is something that we're quite aware of. Head and neck surgeons will perform unilateral neck dissections and remove or tie off the internal jugular vein. And more often than not, those patients are fine. We all know that if you do a bilateral radical neck dissection, then those patients will likely get cerebral edema. But these case reports would suggest that this surgery has been performed on their only truly functioning internal jugular vein, and they have all symptoms of raised pressure. So I'm going to put forward here a hypothesis as to why patients will get pulsatile tinnitus and indeed raised pressure. So this is a normal patient. There's blood. CSF comes out into the venous blood down a constant pressure gradient of 3 millimeters of mercury. It then drains out of the head, going down towards the heart. And you've got two internal jugular veins, and you've got some excess collaterals that come out, allow the blood to drain out of the head. But in some patients, they are very much dominated by this one internal jugular vein that allows blood to escape. And indeed, if you narrow that vein by compression, mild compression, then what happens is you stop getting this constant laminar flow out, venous flow out of your head, and it converts to a pulsatile flow dominated by arterial flow into the head. So the blood rushes into the head, and because there is a narrowing of the vein at this point here, the blood then is squirted out of the head. And so this laminar flow is converted to an abnormal pulsatile flow that is then perceived as pulsatile tinnitus. And if that compression is really quite significant, then of course it increases venous pressure, which in turn raises CSF pressure. So there have been a number of papers describing management of venous pulsatile tinnitus, or venous hum, vascular pulsatile tinnitus. One is sigmoid sinus dehiscence. You've got dehiscence here. So one would perform a cortical mastoidectomy and resurface the sigmoid sinus. And that seems to give very good results in those patients that have got dehiscence. And the argument is that patients have got very turbulent blood flow in the sigmoid sinus because of upstream venous sinus narrowing. This is often seen in these same patients. And this causes a vascular bruit, and this turbulent blood flow seems to result in a change in pressures. And there is gradual erosion of the bone over the sigmoid sinus that allows this breakout of a bruit into the temporal bone once the sigmoid sinus is dehiscent. And therefore, by resurfacing it, one can stop the pulsatile tinnitus going through to the ear. I'm not entirely sure about that as a hypothesis. I'm not entirely sure there is a good, but it clearly works in some patients. And the reason, there's other papers that have come out suggesting that that this bony dehiscence only occurs just as frequently in those patients who have raised intracranial pressure that do not have pulsatile tinnitus. And indeed, when I've looked at my series, only 3% of patients have sigmoid sinus diverticulum. So there's a lot of patients that don't have it that also still have the symptoms. There's been a lot of interest around arachnoid granulation within the sigmoid sinus that can cause a bruit that is then perceived by the ear. And indeed, my colleague, Nick Higgins, published the first case of venous sinus stenting in the Lancet back in 2002. And indeed, now most major neuroradiology, interventional neuroradiology departments are performing venous sinus stenting for some cases. And this was a case of refractory idiopathic intracranial hypertension. She had a transverse sinus stent put in, which improved her pressures. So this is arachnoid granulation causing an increase in venous pressure. And he published a series of patients, but found that a significant proportion in later cases didn't really get better. They were unchanged. And we thought that maybe there was another reason for it. So he was stenting the transverse sinus, but we also thought, well, maybe there's something going on in and around the internal jugular vein. And I want you to show you this case. This is a gentleman who was a jockey who was referred to me quite early on. He's had major surgery. As you can see, he's a jump jockey from Newmarket. He's got a foramen magnum decompression here. He's got a shunt here to reduce pressure. And he's been falling off his horse pretty much constantly. He's a hard, tough guy, but he's crippled by headaches, even despite all this intervention. And I want you to look here. So this is a tiny, so his blood is all coming out of his right jugular bulb. This is your right jugular bulb here. He's got nothing really coming out of the left side. And I'm going to follow this down. So I want you to see the internal jugular vein as we go down. So these are serial slices. As we come out of the skull base, we're now at the internal jugular vein. And what you can see there is the internal jugular vein compressed between the styloid and the transverse process of the C1 vertebra. And if you look here, you can see the veins coming out across the transverse process and being caught and narrowed. So this was a stent that was placed between the two, but we quickly found, and this was published for refractory idiopathic intracranial hypertension, we've done a lot of work on that area to improve venous outflow to reduce intracranial pressure. But we found that this didn't really work very well because you got problems with the stent, and patients could get weakness of the shoulder and other symptoms caused by accessory nerve compression. So we then looked at removing the transverse process and the styloid high up at the skull base to improve venous outflow first of all. And indeed, doing that, we found that a lot of patients got better after that and didn't require any further intervention. There were complications of the intervention. This is for stent, this is for surgery. The pressure of the stents did cause some issues and they fatigued. And there's been one or two complications associated with the surgery. And the vast majority of these cases were performed on patients with refractory idiopathic intracranial hypertension. Here is the stent around the transverse process and then removed, and you can see that it lies in a better position. So just to finish off now with, I think we're pretty much there. Yeah. As I say, all these cases that were done here, these were done for refractory idiopathic intracranial hypertension, but I do have some patients that were treated with a primary diagnosis of pulsatile tinnitus. So they've got this whooshing venous pulsatile tinnitus, and these are the long-term results over a year after they've had the surgery. And so they've had surgery and some stenting, and what we can see is that a large proportion of these patients are feeling much better. Some have had a slight improvement and some haven't. This patient actually, who describes her symptoms as worse, is actually delighted with her outcome because she had a whole bunch of other symptoms that have resolved. And indeed, it is the pulsatile tinnitus that is the hardest symptom to treat. So you can do this type of surgery, type of procedure, and the other symptoms, which are head pressure, fatigue, fogginess of thought, poor concentration, that accompany the symptoms of pulsatile tinnitus, are much better treated by these procedures than the pulsatile tinnitus. And I suspect what's happening is that we're relieving the compression, reducing the venous pressure, but not quite giving enough space for this to reduce this pulsatile outflow of venous blood. And indeed, one can treat that by putting a stent in afterwards. But many of these patients don't want that because they're actually quite happy with where they've got, and they don't want a stent. So finally, in conclusion, I think it's really important when you look at a patient with pulsatile tinnitus is that you look at them with an open mind and don't think that everything's a glomus tumour, and go for an MR scan because you just want to make sure you don't miss a tumour. So look for all ENT causes, and if you use a methodical approach, as I've described, by thinking of all these various reasons why you can get pulsatile tinnitus, then you'll get between 20 and 25% of cases quite quickly. But it'll also give you a really clear idea as whether this is a venous, a vascular tinnitus, more because of the whooshing and the pressure on the neck stopping the pulsation and everything else being normal. And then you really also want to ask those other symptoms, whether these patients have got symptoms that are suggestive of mildly raised pressure, and then reassuring them that this is not something that's going to kill them, that there isn't something that's going to pop, and actually, you know, the symptom isn't a harbinger of something serious. And often when you do that, these patients are very much more relaxed and are very happy to leave well alone. But they do have to be investigated appropriately. And if you want to go further than that and want to look at treating these patients with venous hum, then you do need an interventional neuroradiologist that's going to be interested in the area, because otherwise you're going to get nowhere. And also you need support of your neurologists and neurosurgeons. Lastly, and I think this probably is the most important thing, is that if you're told that a patient has got normal pressure because it's below 25 centimetres or below 26 centimetres of CSF, then that doesn't mean it's normal, and it could actually be causing the pulsatile tinnitus. So thank you very much.
Great, thank you so much, Mr. Axon. Are you happy to take a few questions, if that's okay?
Yes, I am.
Great, so we've got one question from Janine, and you sort of touched upon this in halfway through your conclusion, but should the first assessment to be performed in a pulsatile tinnitus, should it be the CT or should it be an MRI, MRA?
Yes, so I think for me, when I take a history, and the history will push me in a particular direction. So it's very rare for a patient to have an inner ear hearing loss with pulsatile tinnitus. So I would advise that an MR scan isn't necessary. I would go for a high definition CT scan. I would go for a high definition CT scan and CT venogram if they also describe symptoms of raised pressure. But if they didn't, then only a high definition CT. And then if that all came back as normal, then we discuss it and see whether we want to go further.
Great, thank you very much. I've got a two-part question from Victoria. The first part is about whether would you see pulsatile tinnitus in patients with carotid stenosis if you could hear an objective bruit on auscultation. And then the second part is regarding onward referral and management. What would make us, reviewing these patients, suspect a diagnosis of intracranial hypertension, and how would you what criteria should be followed for referring onwards, example, to neuro?
Yeah, so the first part is absolutely, if a patient presents with pulsatile tinnitus, you need to listen to their temporal bone and neck. If you put your stethoscope on their head, anywhere on their head, and they've got a clear bruit, then that's likely to be a dural fistula. If you're hearing it in the neck, then one should consider carotid stenosis and should consider referral to a neurovascular surgeon for review. I've done that on a few occasions and very rarely thrown anything up, although there are papers that do suggest that it's a cause and can get better and once the carotid endarterectomy is performed. With regard to referral onwards, yes, so if you suspect that there is pressure-related, this is a pressure-related symptom, then in the series that I presented, 25% of those will have clear idiopathic intracranial, or 22% will have idiopathic intracranial hypertension. So yes, they should be referred with a thought that this might be raised pressure, and a lumbar puncture should be considered. But 75% will not meet criteria for idiopathic intracranial hypertension, and it's likely that those neurologists will then turn around to you and say that this is normal. And that often it's at that point that patients are then told that everything is fine, everything's normal, don't worry about it, you haven't got anything wrong with you. And it's that point where the relationship between the doctors and the patient can often break down, and often why they then go to other surgeons looking for a solution.
The potential trajectory might be there that a symptomatic patient gets referred with suspicion of IIH, gets referred to neurology, and only when their investigations come back normal, for want of a better word, then we would consider the surgical and maybe refer on to services such as yourself. Yeah. We have an anonymous question. Do we know why only a few patients with SSCD suffer with autophony and the pulsatile tinnitus and others don't?
Yeah, no, that's a great question. I don't know. I really don't know why. Radiological evidence of superior canal dehiscence, I think, can be up to 9% or something on some studies, where temporal bone studies, I think it's quite a bit less than that. So there's an issue with radiology as to whether this is an accurate test or not. I think that temporal bone studies showed about 2%. Radiology studies about 9%. Patients who have actually got the symptoms, far less than 2%. So why a patient would have symptoms with a hole and why they wouldn't, I don't know. But what I do know, and it's a study that we're about to publish, is that pressure is related in a proportion of them. In fact, that likely there are two groups of patients who some have remodeling of their temporal bone due to pressure, and others just have a congenital issue that becomes apparent at some point in their life. But no, I can't answer that question.
Okay. Food for thought, I suppose. I've got two further questions. One is from Ellie, and she's asking about ophthalmology reviews in those patients that we suspect IIH. How sort of stringent should we be about referring for ophthalmology?
Yeah, so it's whether you go first. I think in the superior canal patients that I've had that have also had tegment dehiscence and some had CSF leaks and so forth, I've referred off for ophthalmic review. And of the 60 patients that I looked at, 8 had papilledema. So it is a present, and I think if as I say, 22% have high pressures over 25, then it's likely that some of those will have papilledema. So I think it's worth considering review. I've got a very good relationship with our ophthalmic team, and they're very happy to review if that's suspected.
Then we've got a question about, just bear with me a second just to get it phrased correctly. What proportion of pulsatile tinnitus patients sent to you in your referral service do you think have had misdiagnosis, could have been picked up by their initial presentation? And based on that, what have you recognised as the common pitfalls people are missing earlier on? Yeah.
So as I mentioned at the start, I think that ENT surgeons are very good at identifying pulsatile tinnitus causes of ENT causes of pulsatile tinnitus, and CT temporal bones, high definition CT temporal bone is absolutely essential. And not only should you get the report of your neuroradiologist or radiologist, you need to look systematically at the scan. You need to go through every part. Is this a middle ear cause of pulsatile tinnitus? Is it an inner ear cause of pulsatile tinnitus? Is there dehiscence of the sinuses? And just go through it yourself. So once you've done that and you're convinced that the temporal bone is normal, then one thing that a lot of people will not do and not really be aware of is this pressure on the neck. And if you are able to stop the flow of blood by pressure on the internal jugular vein, and their pulsatile tinnitus stops, then this is a venous or vascular tinnitus. And at that point, then you've likely got a diagnosis on which to start talking about.
Thank you. I think that partially answers the question I've got next, which is from Mila, who said, what in the history or anything in the examination would make you satisfied that patient has a somatic pulsatile tinnitus and would not warrant further onwards investigation? Is there anything, or would you actually?
Yeah, this is really good, because when I started down my pulsatile tinnitus with my pulsatile tinnitus interest, I didn't take much interest in the frequency of the pulsatile tinnitus. And I ended up treating a couple of patients quite aggressively because they're really quite troubled by their tinnitus. In retrospect, I suspect that they had pulsatile tinnitus, so somatic tinnitus. So now I'm really careful to ask whether it's high frequency ringing or hissing, whether they've got multitonal tinnitus, whether there's a sensorineural hearing loss, bilateral sensorineural hearing loss. Can they control it by pressure or head pressure or gritting their teeth? These are all classic symptoms of somatic tinnitus. And is there hyperacusis? Was there a trigger? And so they're very different to the other group, the more common group that is this whooshing, low frequency whoosh that dominates those patients that do not have somatic tinnitus.
Thank you very much for that. That was really helpful and a really great talk. And